Hi, Dr. Brian Kaufman, a retired family doctor, a CLL patient myself, and the co-founder, executive vice president, chief medical officer of the nonprofit CLL Society here at ASH 2022.
Hi, I'm Dr. Talha Munir. I'm a hematology consultant working at St. James's Hospital in Leeds, UK. It's an absolute privilege to be here at ASH 2022 in New Orleans.
Dr. Munir, we've developed some very excellent prognostic factors in CLL, and one of those is whether or not your immune globulin, your IgHV, is mutated or unmutated. So I'm going to ask you to explain that a little bit in relationship to this trial that you did, which gave an answer that on first impression looks a little counterintuitive, but I think you have an explanation of why this happened. And it was a combination of Ibrutinib plus Venetoclax with MRD-driven, so measurable or minimal residual disease-driven duration of treatment results in a higher rate of MRD negativity in IgHV unmutated than mutated CLL. Update interim analysis of the FLAIR study. So can you explain that in a patient-friendly way?
Yeah, so the IgHV status in a CLL clone is one of the most important predictor of time to first treatment. So we know that people's CLL clone which harbors this unmutated IgHV, which means that this kind of CLL clone is very much sensitive to grow very quickly. These patients progress very quickly, and traditionally when we have given chemoimmunotherapy to unmutated IgHV CLL patients, the responses have been poor, and usually the patients relapse within 2.5 to 3 years after they have treatments like FCR or bendamustine rituximab. Whereas the patients with mutated IgHV, which runs a very indolent course, respond very well to chemoimmunotherapy. So our trial, FLAIR, was an adaptive trial design, which essentially, when we developed it back in 2014, compared FCR to Ibrutinib rituximab, and that data we've shared before. But then we adapted the design because we knew that there are changes in the world of CLL, and we had two arms which looked at Ibrutinib on its own, or we combined with Ibrutinib with Venetoclax in an MRD-driven approach. And in this update, what I'm presenting here at ASH is looking at how potent this combination of Ibrutinib with Venetoclax is, and what we found was that patients with unmutated IgHV, which is the bad risk group, actually respond very well to this combination.
So that would be counterintuitive. This is the high risk group, at least with chemo, so why do you think that they respond better than with the mutated group?
That's a very good question, and I think the main reason for that is that we know that unmutated IgHV patients benefit the most from BTKI inhibitor therapy. So if you look at all the Ibrutinib data, the unmutated IgHV patients are the patients who are benefiting the most from Ibrutinib-based therapy. And if you consider that your CLL clone is in a proliferative environment and it's growing very, very quickly in the lymph nodes or in the bone marrow, what you want is to get them out quickly, and what Ibrutinib is very good at doing that is gets those cells out quickly, and then the Venetoclax can kill those cells at that point. And the shifting of the cells, the best we see is in unmutated IgHV patients. So that was the reason or the rationale behind using this combination, and when we hypothesized that, but it's good to see the results that actually the unmutated patients are benefiting from this combination.
Well, it also reminds us that you've always got to be reassessing your data, because the prognostic factors that apply to chemoimmunotherapy like FCR or BR don't necessarily apply with the novel or targeted agents. There's a whole different understanding of how they work. Another example is 11q, which actually does better with Ibrutinib while it does much worse with chemoimmunotherapy.
Yeah, we found the same thing with our Ibrutinib with Venetoclax combination in this data. We were looking at the MRD analysis, and if you look at two group of patients who are benefiting the most is the unmutated IgHV patients and the 11q deleted patients. So at 2 years time point with combination of this therapy, 80%, more than 80% of the patients, which means 4 out of 5 patients, were MRD negative or minimal residual disease negative, which means that I cannot pick out 1 in 10,000 cell, which is a CLL cell in their blood or bone marrow at this 2 years of combination, which is nearly unheard of in CLL space. And same was true about the unmutated IgHV patients. So by using these combinations, we are able to define which patients might get the best from one combination or another combination.
Well, those results that's pretty encouraging. 80% you can't find the disease in their bone marrow, which is harder to clear, and in their blood. Were there any safety concerns? These are two very powerful drugs that you're using together.
So at the moment, with the 2-year follow-up, we're not seeing any major issues at all. There was some tumor lysis syndrome that we saw.
Remind us what tumor lysis is.
The tumor lysis means that when we give the drug called Venetoclax, it kills the CLL cells, and the CLL cells can release chemicals in the blood. And those chemicals, if we don't pick it up, then it can cause problems to kidneys and a few other issues. But there are two distinct things. One is called biochemical tumor lysis, which means that we see changes in the blood and we pick it up and sort it out straight away. And then there is something which we always tend to avoid, is clinical tumor lysis, which causes problems. So all the cases we saw was biochemical tumor lysis, and it was all managed. There was no issues really, and we feel very comfortable in using the combination.
Good. So these are incredible results, very encouraging. Any final thoughts or conclusions you think you want to share with the patient community?
I think all I would say is in FLAIR study, we've got the data now for half of the patients. The other half we will be presenting next year. And then we will be able to share the long-term data looking at whether the things we're finding now in the short-term endpoint, like minimal residual disease, will be corresponding to progression-free survival data, and few other bits and pieces where we are kind of comparing multiple arms of this study. So I'm pretty sure that in the next 2 to 3 years' time, a lot of more data will come out from FLAIR study.
Well, I love the way you could adapt the study and change with the times. This is one of the things that you and Dr. Hillman have been able to do, is change studies almost on the fly very quickly, which is not always possible in the US. I've been really impressed with that. So congratulations on that. And thank you very much for doing this research. I know a ton of patients are interested in this combination. Dr. Munir, I always learn something when I talk with you. Thank you so much.
Same here, it was my pleasure.